All right, welcome to The Explainer. Today, we're going to break down Graves' disease, but we're doing it by walking through classic clinical case, from the very first symptoms all the way to those critical management decisions you're going to have to make. So let's jump right in.
Okay, let's dive right in with a patient I guarantee you're going to see. A 35-year-old woman comes in, her heart is racing, she's feeling anxious all the time, and she's losing weight, even though she says she's eating everything in sight. With that classic trio of symptoms, your brain should be screaming hyperthyroidism. It's got to be at the very top of your list.
And then, when you ask a few more questions, the whole picture just snaps into focus. She tells you she's always feeling hot, sweating way more than usual. She's tired and weak, and her periods have been all over the place. These are all the hallmark signs of a body in overdrive, a hypermetabolic state, and our number one suspect is a very overactive thyroid gland.
So here's our game plan. We'll start with her initial presentation, then we'll walk through how to nail the diagnosis. We'll explore how this disease affects more than just the thyroid, cover the three main treatment options, and wrap up with a life-threatening complication you have to know how to spot.
All right, so we're back with our patient. All the signs are pointing towards thyroid disease, right? But, a suspicion is one thing. Now we've actually got to prove it with some hard data. And that leads us to a really key question. You've got a bunch of tests you could order, but which one is the single best, most sensitive, most cost-effective first step? The answer to this is really the cornerstone of the whole diagnostic workup.
Okay, let's crack this diagnosis by following the biochemical trail. The lab work is what's going to take us from I think it's this to I know it's this, and it's going to guide every single decision we make from here on out.
Okay, first things first, let's get our vocabulary right. The big, broad term is thyrotoxicosis. Now, all that means is there's too much thyroid hormone floating around in the blood. Our job, then, is to be a detective and figure out why. Is the thyroid gland itself going haywire and making too much, or is something else causing it? And here is that diagnostic algorithm in action. Step 1, you always start with a TSH. In a case like this, the pituitary gland in the brain sees all that extra thyroid hormone and just slams on the brakes. That makes the TSH level plummet. So a low TSH is your green light to then check the actual thyroid hormones, the free T4 and T3. And when those come back high, boom, you've confirmed thyrotoxicosis. So we know there's too much hormone, but why? Well, in Graves' disease, the bad guy is this specific autoantibody, thyroid-stimulating immunoglobulin. You can think of it like a skeleton key that fits perfectly into the TSH receptor. But instead of just turning it on and off like it's supposed to, it breaks the lock and jams the ignition, hot wiring the thyroid to stay permanently on. So this is what's happening under the hood. It's basically a case of friendly fire. The body's own immune system gets confused. T cells tell the B cells to start churning out these rogue TSI antibodies. And these antibodies just completely bypass the brain's control system, putting the pedal to the metal on the thyroid gland, telling it to make more hormone and to get bigger, which is exactly why we see both the thyrotoxicosis and the goiter. So you can measure these antibodies directly in the blood, which is one way to diagnose Graves'. But another really elegant way to figure this out is with a radioactive iodine uptake scan, or an RAIU. This test is awesome because it answers a simple question. Is the thyroid factory working overtime, or is the warehouse just leaky? In Graves', the thyroid is hungry for iodine to make new hormone, so the uptake is high. But in something like thyroiditis, the gland is just inflamed and leaking stored hormone, so the uptake is low. It's a key differentiator. Okay, so we've nailed the diagnosis, Graves' disease, and you might be tempted to think, great, it's just a thyroid problem. But nope, that's not the whole story. This is a systemic autoimmune disease, and that same autoimmune attack can pop up in other parts of the body in some pretty dramatic ways. And the number one place this shows up, outside the neck, is in the eyes. About a quarter of all patients with Graves' disease will develop some form of what we call thyroid eye disease, or Graves' ophthalmopathy. So what's happening here is that same autoimmune attack is causing inflammation and swelling in the muscles and fat behind the eyeball. This is what causes that classic bulging look, what we call proptosis. It could even mess with the eye muscles and cause double vision. And this isn't just cosmetic. In really bad cases, it can actually squeeze the optic nerve and threaten vision. And listen, this is a huge counseling point for your patients. Smoking makes this so much worse. Now, here's another classic, though much rarer sign you might see. It's called pretibial myxedema. It's a weird-looking skin condition where you get these firm, waxy plaques, usually over the shins. It's caused by the same autoimmune process. And while it's not common, when you see this, plus the eye disease, plus the goiter, that's pretty much a slam dunk diagnosis for Graves' disease. All right, diagnosis is in the bag. Now for the big question. What are we going to do about it? When it comes to managing Graves' disease, we basically have three main pillars of treatment, and the right choice really depends on the patient sitting in front of you.
First up, we have our medications, the antithyroid drugs like methimazole. These work by getting inside the thyroid and blocking the production of new hormone. This is usually where we start, hoping we can cool the thyroid down and maybe even get the patient into remission. Our second pillar is radioactive iodine. With this, the patient just swallows a small pill. The overactive thyroid cells greedily soak up that iodine, and the radiation that's attached to it then quietly destroys those cells. It's kind of like a targeted internal radiation treatment that quiets the gland down for good. And pillar number 3 is the most direct approach, surgery. A thyroidectomy is exactly what it sounds like. We just go in and remove the thyroid gland, which is the source of the whole problem. It's a quick and permanent fix.
Okay, this table is absolutely crucial because it lays out the pros and cons of each option. With the drugs, you get about a 50-50 shot at remission, but you've got to warn them about the super rare but super serious risk of agranulocytosis. Both radioactive iodine and surgery are pretty much guaranteed cures, but they also guarantee permanent hypothyroidism, meaning they'll need to be on thyroid hormone for life. Each choice has its own set of risks, and this is why you have to sit down and have a real conversation with your patient.
Okay, last section, and we've saved the scariest for last. This is the one thing you absolutely positively cannot miss. This is the biggest red flag in all of thyroid disease.
We're talking about thyroid storm. This is way beyond just having high thyroid levels. This is a full-blown decompensated crisis. And what's key here is that thyroid storm isn't about how high the lab values are. It's a clinical diagnosis. It's about the body's catastrophic reaction. We're talking high fever, confusion, and cardiovascular collapse. This is a true medical emergency with a scary high mortality rate, and it's usually kicked off by some stressor, like an infection in a patient whose hyperthyroidism wasn't under control. When this happens, you have to move fast and hit it from all sides. This is a 4-pronged attack, and the order matters. 1. IV beta blockers to get the heart rate and blood pressure under control immediately. 2. A big dose of ethionamide to stop the factory from making any new hormone. 3. An iodide solution to put a cork in the gland and stop it from releasing the hormone it's already stored. And, this is so important, you give the iodide after the thionamide. And 4. IV steroids to block the conversion of T4 into the more powerful T3 out in the body.
And that really brings us full circle, because the best treatment for Graves' disease is never a one-size-fits-all answer. Think about our patient. She's 35. What if she wants to start a family? Suddenly, the whole conversation changes. You have to think about the risks of these treatments during pregnancy. This is where the art of medicine meets the science. You're not just treating a TSH level, you're treating a whole person with their own life, their own plans, and their own future.